And good afternoon. Very welcome to this session of the Challenging Conversations series, which is run by Maudsley Learning. This is a series where people give their views, their very frank and open views about the things that really matter to them. This series has touched on many subjects. Should we still be prescribing medication? Is restraint a word that should ever be used in connection with psychiatry? What does equalities truly mean? How do we actually do diversity? Should training the clinicians of the future look like? We've had many people on this series, but today I'm hugely pleased to welcome 4 young mental health trainees who want to talk about what matters to them. I hugely admire their courage in coming on, because I do remember as a trainee feeling so passionately about the things I wanted to change throughout my career in mental health, and never quite been sure if there was a safe place for me to do it. So what this Challenging Conversation series offers is a safe place for people to share challenging views openly. What happens to this series? We put it on YouTube. You're welcome to look at it. We encourage people to find safe places in their own organizations to debate challenging issues. We at South London and Maudsley, because Maudsley Learning is part of our wider family, we also use these conversations to inform our organization's strategy about how we want to go forward and the type of care we want to provide for local people. So, great. So I am going to start off in the usual way for this series by asking one of our participants, the wonderful Victoria Chamorro, if she would kick us off by saying, Victoria, what do you want to challenge us about? What do you feel challenged about? What do you want to see the future of psychiatry showing from your perspective as a trainee at SLAM?
So hi, my name is Victoria and I am a registrar at SLAM. The big thing for me, I think, is communication. And I think on our radar is to improve communication with patients and their families. But I would like to see this kind of a little bit more broader. And firstly, providing reliable sources of information, kind of digital formats, ways that patients can access reliable information throughout the whole of their lives, not just kind of at diagnosis or at medication. And I feel that we miss an opportunity with that. The other thing is I think that we really need to improve our public relations and have better communication with the public. I think just having better communication with the public would have a massive impact on public health. And as we know, mental health is so strongly influenced by all the kind of social determinants and socioeconomic status. We really need to get our message out there. And having a kind of dip in the toe at looking at communication with the public field. There are very few psychiatrists there, and I think that we need to get our narrative out there so we can reduce inequalities that affect our patients. Because unless this is on the public agenda, and it won't be unless we tell people, we won't be able to make policy changes or anything like that. And I've had quite a lot to think about what's holding us back as psychiatrists from doing this, because psychiatrists on a whole are people that have a wealth of kind of humanities interests, and there's a lot of overlap with all kinds of different spheres like film and arts and kind of philosophy and things. And why aren't we out there? And I think a lot of that is kind of a feeling of kind of self-stigma. I think that there's a fear that there will be this huge backlash against us, or maybe we're not qualified enough, or everyone's narrative is different. And I think now times are finally changing and it seems to be in the public eye. And I think that we need to fill that void to provide good quality, reliable information that will improve the lives of our patients. So yeah, that's my thing. Oh, Geraldine, you're on mute.
Thank you, Victoria. We'll come back to you about what do you mean about patient information? What good examples have you seen? What are you proud of or not proud of in the information you've seen? I have to be honest and say, when I was a trainee, there was the beginning of soaps on television. And we used to think if we could just have a soap, and I sat with a team leader and he said, let's have a soap about a community mental health team, and we will never mention the patients, because we don't need to. It'll all be about the team and the staff. So I think we created about 8 episodes, which I would love to show on a thing, just to show what the reality and the fun is like. Because maybe, as you say, the arts is a better way to communicate than some of our more dry messaging that we do so terribly badly in mental health. Okay, let me come on to Romy, if I may call you that. Romy, yeah. Introduce yourself and talk about your challenge to the future.
Thank you. So my name's Romy, or Romayne, and I'm fairly newly CCT'd from SLAM, and I work as a clinical research fellow in the affective disorders at the IoP. I'm one of the chairs of the Royal College of Psychiatrists Digital Special Interest Group, so that can give you an idea into what I'm interested in. I'm really interested in kind of the effects of mental health on technology and what it means for our speciality kind of on the whole going forward. So there's quite a few sort of challenging things within kind of the digital space and mental health that many of us, whether we like it or not, have had to face this year, kind of propelled by the pandemic. I say that no matter what speciality you're in, you've had to think digital. You've probably had to rethink your entire way of working, as well as having some sort of social life or family life as well that involves digital. So I think there's a few things that are really important, like digital inclusion, what it means for our patients that can't either access or use technology. It's about how we use technology to spread some of those messages that you were talking about, Victoria. I also think it's very interesting that there's something like 10,000 mental health apps available for you to download, and we don't know much about standardization, safety, efficacy. And then we see more in research, as well as from kind of commercial entities, people using our data. And I think that's amazing when patients are telling me they're kind of like Fitbit sleep data, and that really gives me a great insight with my bipolar patients. But on the other hand, if companies all have this data, what does that mean? So I think there's a lot of challenges we could talk about today.
Fantastic, Romy. Very, very well described. And I feel so pleased we've got you on the panel today, because there was a period probably about 8 years ago when people were saying, let's digitalize. And then I don't know if you remember, there was a wonderful guy from America, Robert Wachter, who came and he went, the whole point of digitalization is not to go digital. It is to improve the lives of patients, staff, society. It's the wider agenda. And you have absolutely articulated that. So let's keep coming back to you about whose life is going to be improved by digital and who might miss out if we don't get our challenges addressed in the right way. Amelia, introduce yourself and tell us what's your passion to see in the psychiatry and the mental health of the future.
Hi, yes, I'm Amelia, and I'm a core trainee at Central North West London Trust. And thanks so much for inviting me on. I'd like to just talk a bit about sustainability within psychiatry, and particularly in relation to the climate crisis, which is definitely a challenging conversation. And yeah, it's sort of widely accepted now to be the greatest threat to human health of the 21st century, and its effects are already felt worldwide, with the developing nations bearing the brunt of it. So I think it's becoming increasingly relevant for psychiatrists to be aware of how climate change impacts mental health, because in the future we will likely be managing populations who've experienced climate-induced displacement or conflicts due to scarcity of resources, fires, droughts, floods, and all of these have a range of mental health impacts. And I think perhaps an underappreciated fact is that there are already 25 million people displaced by climate change, and this number is on the rise as more and more areas become uninhabitable. And I think the UN have predicted there'll be up to 1 billion people displaced by 2050. So our services will need to be resilient enough to support the needs of a growing migrant population, as well as the impacts of extreme weather like flooding here in the UK. And there's also eco-anxiety, which is on the rise, which has been described as a fear of chronic environmental doom. So last year I came across a patient in a CAMS eating disorder clinic she was really fearful for the future of the planet, and she described this deep sadness for the loss of the natural world, and she felt really hopeless and also guilty about her own sort of existence and contribution to the problem. And she articulated that she was aware that her eating disorder was delaying her puberty, which gave her a sense of relief because she didn't feel ready to confront these issues as an adult. So I think environmental sustainability really is critical within our specialty. Yeah, I think it basically means providing high value care now for our patients, but also for our future patients. And given that the NHS is a massive emitter, in fact, I think it's the biggest emitter of greenhouse gases in the public sector, it's pretty relevant to us. Yeah, do you want me to, I could talk a bit about sort of vision for the future, or should we leave that for?
Let me come back to you, Amelia. You've set the scene absolutely beautifully, but the kind of level for us as individuals, the service changes we have to think about, but also the kind of the macro global level, because I think the globalization is really a big issue. But let me come back to you, because I'd love to hear more about your views on how practically can we change things. If you were advising the CNWL board where you work, and we're advising the South London Maudsley board, what are the key messages, the key 3 or 4 things we should be doing as part of our organization strategy and for each of our teams to try to reduce the kind of the impact of climate change? How can we play our part? And so let me come last but not least to Jonathan. Jonathan, please introduce yourself and tell us your passion, your challenge to the future of psychiatry.
Thank you so much. Yeah, so I'm a specialty registrar doing general adult and old age psychiatry, but most of the time I am doing a PhD at UCL looking at catatonia and trying to untangle some of the neuroimmunology of this disorder. So I suppose what I'm most passionate about and where I see quite a bright future over the next couple of decades is in better treatments in psychiatry. And firstly, in terms of biomarkers, and I think people get us wrong when we think about biomarkers. I think I'm fairly pessimistic about the prospect for a biomarker to diagnose depression, say, because if you have the biomarker but you don't feel depressed, what use is that? But where biomarkers can be really useful is in identifying less common neurological or medical disorders like encephalitis. And also, and that's already happening, and that's part of my research, but also we're really on the cusp of biomarkers for treatment response. So in terms of efficacy, we know that if you're depressed and you have high inflammatory markers, your chance of responding to an antidepressant is much lower. And in terms of side effects as well, we have genetic testing, which is being used in epilepsy clinics for carbamazepine, for instance, to predict whether you'll develop Stevens-Johnson syndrome if you're prescribed it. So I think there's enormous potential just in the next few years for biomarkers translating into clinical practice. And just so I don't play the caricature of a biological psychiatrist, I think actually the other area that's really translatable is new psychological therapies. It's not flashy, it doesn't make the front pages of the newspapers, but actually psychological therapies have developed enormously over the last 20, 30 years and are translating into all kinds of areas of medicine. So CBT for insomnia not only is as effective as hypnotics in the short term, is more effective in the long term and doesn't produce the tolerance and the dependency that hypnotics develop. I think there's all kinds of potential for psychological therapies to move into emergency departments, into chronic medical conditions, adherence, etc.
Wonderful. So you are not the typical boffin biological scientist who sort of says, yes, it may take 17 years from discovery to it actually happening on the ground, but I'm intellectually fascinated by the discovery. Wonderful. Love your attitude. I also love the fact that when I was a senior registrar level at SLAM, people started talking about genotyping and being able to give exactly the right medication to exactly the right person and exactly the right dose to avoid side effects. And that was 40 years ago, and I'm still waiting. So you have given me real hope, but I'm going to come back and challenge you on what's the reality of the biomarkers. How far away are we from it happening on the ground? So 4 really, really fantastic perspectives from very different people focusing on very different things. How feasible is it to get some of these into the curriculum? So let me start. Victoria, you want patients to have better information. Information is power, whether it's numbers or information. Have you seen any really good examples? If you or a friend or a family member were to become a patient somewhere, have you looked on any website and thought that's where I would direct them to go, because that will really help them understand how this might have happened? You know, what will it be like? What might make me better? Have you come across that at all?
I have, and I think I second your comment before about actually sometimes the arts say it more than a sentence describing symptoms. In particular, and I'm going to let myself down now because I can't remember the full title of the film, but there was an award-winning film from 2 years ago, and it's only 5 minutes long, and it shows how a woman cannot bond with her baby and the result of postnatal depression on the bond, and how devastating it is for the mother and for the baby. It's incredibly impactful. And again, it's only 5 minutes or 8 minutes long, and within those 8 minutes, it tells a lot more than leaflets and that sort of thing would be. I would very much like to see that sort of thing impacting on the narrative, and then we would see, I suppose, less or more appropriate use of kind of Hollywood films, because it would be affecting the narrative. So for every One Flew Over the Cuckoo's Nest, we can have these realistic and empathetic portrayals of our patients' narratives. And I think that's what's lost, is the patient narrative. And that's the hook that really draws people in to understanding the situation, not just kind of the bald facts, which can come across very dry. The other thing is, I think that psychiatrists are kind of these shadowy figures that no one really knows about, and we don't really seem to have kind of control over our own narrative about mental health. And I think just improving access to patients, which I think as psychiatrists we can be quite frightened about on a kind of personal level, not just in clinic and in our own clinical spaces, would massively change the narrative in the public sphere as well.
Wonderful. You know, you reminded me, Victoria, if I remember when I'd been National Clinical Director for just a few weeks, and I was asked, would I go on a radio program, a bit like this, to talk about mental health or answer questions that the public would ring in about mental health. And the interviewer said to me, Dr. Strathdee, it's probably important to know that, you know, you'll have to do a lot of talking because almost nobody ever rings in to ask about mental health. And so I was kind of busy formulating what I kind of might say. And wonderfully, I didn't have to say a word almost the whole time, because people did. And it was one of the very first times, exactly what you said, they rang in. And the stories I remember, you know, was one woman who said, I used to provide childcare for my grandchildren, and I became depressed. You know, we fell into debt. My daughter lost her job, and she's not been able to work because I can't do the childcare. We've had to move into a really dodgy flat in feels very unsafe estate, and we are really down in the dumps. And we've lost a lot, and the children hated moving school. And then I went to my GP, and she recommended me for this CBT, that's just this new CBT thing. And actually, it's been amazing. We're back on track. I'm now able to look after the kids. My daughter's able to, she's just got a new job. It's amazing. And the stories went on. You know, I'd been at university. I got really depressed. I wanted to be a teacher. I had to leave because I was so depressed. Now I've had the psychological therapy and a doctor I trusted and some good medication I needed. I'm back on track. I'm going back to university. I'm going to do teacher training. And the stories went on and on about the human impacts, not just on oneself, but on one's family, and the economic impact, the kind of the slow fall down into poverty by virtue of having an untreated and unable to access treatment. So let me come back to you, Jonathan. You know, the criticism of research, and I have in the past described myself as a recovered academic, really because I'm not a very patient person, as most people who know me would know. And I thought doing research was wonderful, but it was how could you get it to be implemented routinely in practice very rapidly? And I look today, so if I look at things like the National Audit of Psychosis and some of the kind of the national studies that show how commonly people can actually access evidence-based effective therapies, and there's still a big gap. You clearly want to change that. So by the time you're sitting interviewing people for challenging conversations, that's going to be something of the past. What are your ideas? What should happen for us as a society to be able to use the science more rapidly?
Yeah, I think firstly, you're right that taking a drug from the lab to it being rolled out in clinical practice is years, if not decades. And so I think we probably need to look a little bit more at repurposing existing medications, both within psychiatry and exchanging drugs with general medicine. I think secondly, there needs to be a real look at the bureaucracy around research. It used not that long ago to be very common for jobbing clinicians without any paid research time to be writing up a series of interesting patients that they saw, and that's not as common anymore. And I think thirdly that we need a little bit of a change in attitude in mental health, beyond just risk management, which I fear lots of our front-end services have become home treatment teams and admission towards actually offering therapeutic benefit. So I think there are lots of patients who are severely disabled by common mental illnesses, depression, anxiety, ACD, etc. And they're lucky, so disabled that they might not even leave their home, but they're lucky if they see a psychiatrist in 6 years, because they're not risky in inverted commas. And I think we need to move more towards evidence-based treatments that improve quality of life, rather than just risk management.
Great. So we have a number of people speaking into the chat. So I suppose my question to you all and the people listening to us is, if you look on the website of your own organization that you work on, to what extent does the strategy of the organization say, we know a lot about effective interventions in mental health, but they're not being routinely given to people as fast as possible? We have big delays from referral to people actually coming in. We have major variation in who gets what of effective interventions across the country. What can we do to change that? Romy, do you think digital offers us greater access? Does it offer part of the answer to that research timeline gap and the huge variation between teams and offering effective interventions?
It certainly can play a part, because you can see there's disparity in different parts of England alone on what mental health services are available, how many psychiatrists there are per person, that sort of thing. So digital kind of interventions can help us physically or virtually reach people, shall we say. So that is very important. I also think this kind of global health movement, if we're going back to Victorian communications, is really important in terms of public health. So I think a lot of the time, like you were saying, Jonathan, we're seeing this, we're at the emergency end of things, as opposed to psychiatry really being like a public health issue and prevention being really important. So I think things like social media really have, in some good ways, and there's obviously negatives to it as well, opens up conversations around mental health. Again, in the arts, they're like, rappers talking about mental health when I never would have thought growing up they were the kind of spokesperson for something like depression. And I actually think that's incredible, like absolutely incredible. So I think digital has a part to play, whether that's in the media or the physical delivery through telepsychiatry, certainly.
Yeah. Which brings me to you, Amelia, and sustainability. So one could argue that for the sustainability of mental health treatment and care, we really need to find an answer to getting everybody on board to promote the messages and work towards doing evidence-based interventions. And I just wonder if that's come into your sustainability conversations. Let me just throw an example at you. So at the minute I work, one of the roles of the privileged players working across Pan London to respond to urgent and emergency care crisis situations. And one way that we felt we could get much more sustainability is if each part of the system knew who was coming asking for help early. Why do people come in crisis? What are the preventable social determinants that people are coming with? What are the kind of the most effective treatments for people? And what we find is that across the whole system, about 70% of people in many places are already known to the system, but don't have a care plan that says what might happen to keep them having sustainable good health and to prevent them coming into crisis. We have people coming outside hours. We have a lot of people with very avoidable social determinants. Is there a way, what's your view with your wearing your sustainability hat and thinking about, we will have these millions of people moving across the world. What could we do sustainably to prevent some of the mental illness that we're seeing, as well as to make sure that everybody is providing the same information so we can properly plan treatment, targeted treatment interventions?
Well, I think a big part of the solution would be better communication between areas, so that someone's care plan really can be accessible to anywhere, like within the NHS and maybe even at some point beyond. And then I think it's about addressing the social determinants of mental health to try and prevent crises and relapses in the first place. And I think there are ways that we can do it in a much less resource intensive way. And this will really be focusing on empowering patients to just have more control over their own treatment and management. And I think tech probably does play a big part in that, actually. I'm sure Romy will have an opinion as well. I kind of have mixed feelings about tech, because in a way it feels like we should all be getting away from it to help mental health. But then at the same time, it clearly has so much power to things like online CBT or mood trackers and all these things that can probably keep patients away from having to rely on services as much and promote their independence. It's kind of a win-win. So tech could be one aspect, and sustainable prescribing is probably another big one. So that kind of comes hand in hand with medicines optimization. If you look at the carbon footprint of meds, that's huge. The manufacture and transport and packaging, it's all quite significant. And then on top of that, they're also a recognised group of pollutants now. So there's antidepressants are detectable in water sources all over the world. And there's a growing body of evidence that they're disrupting aquatic life. So this is perhaps another consideration when we're considering the wider implications of our treatments, how that will affect so the food chains, and all of this eventually comes back to a new presentation of mental health.
Really, really interesting thoughts and views. Others questions been asked are, should patients have access to their electronic medical records? Would that help with the population health, the digital dissemination, with getting more people involved in research, with sustainability? If patients, we truly wanted to empower people by giving them much better, more rapid access to the records, would that be part of an answer? Is that what you'd like to see by the time you've been a consultant for 10 years? Would you think you would be in a position where all your patients would be able to get access to their records?
I can start. I think it'd be very, very interesting if patients had access to their records. Depends what that's going to look like. Obviously, sometimes in psychiatry we deal with quite difficult personal information. Certainly, I know at SLAM we're trying out Beth, this new system, to try and get parts of our electronic records available to patients. I work in Optima, or have been recently, and we really try and encourage patients to really take part in their care plans and their crisis plans and their early warning plans. And by having that somewhere really accessible, like their mobile phone, that can be shared with their friends and family, it can make a complete difference into kind of early management of their symptoms. So I think there's certainly a place for it.
Interesting. And you must tell us more about Optima. I mean, we know that with the new mental health, with the review of the mental health legislation, one of the most consistent recommendations is that people are supported to develop with their clinician a relapse prevention, crisis response, advanced decision plan. I've been quite surprised at how hard it is to find examples in teams of where people are doing that already. So this is not simple. This is major culture change. Victoria, population health. What else would you do? Because one of the questions on our chat is, I'm a big fan of early intervention and prevention. Giving children the skills and knowledge to protect their mental health is essential. But how often do we ask the question about why our lifestyles or environment are so toxic their minds need protecting? What role can psychiatrists play in shaping healthy environments and policies?
Well, I think actually, for most people, if you said that it was an environmental issue that created an environment that made somebody become very mentally unwell, I think a lot of people would be surprised. So I think a lot of it is to put it on the radar and to say, okay, this is all not good things, but also making people unhealthy. And actually, it has massive economic implications for the country and around the world. And this needs to be sorted. I think from a policy perspective, it's been well shown that any money invested into mental health repays itself by many folds. And we need to be able to put our weight behind supporting policies that tackle the social determinants of mental health and to more clearly communicate the connection between them. A lot of our mental health difficulties could be seen as social diseases, and we really need to explore that with people and have it as part of the narrative that we're putting forward.
You've heard quite a lot about policy. Have any of you any intention of getting involved in the policy world?
So I'm currently doing a master's at UCL in PPE of health. It's something that would be something I would consider in the future, definitely. And it's kind of opened my eyes to how things work and how policy is made.
Fantastic, because we need people who are willing to get involved in policy. It's a set of skills. If you have clinical skills, they're all transferable. I used to say, as National Clinical Director, my best training was having been a consultant psychiatrist working in assertive outreach, where you find people, anybody that you, anywhere, any place, any time that you can persuade to work in a way that's going to be helpful to them and the system. It's having those kind of clinical skills taken to a different level is incredibly helpful. Romy, you mentioned, however, and it's again something Amelia's brought up, is about the people that might get left behind in this world vision going forward, the digitally excluded. You've obviously given that a lot of thoughts, and so I imagine that will feature in your special interest group thinking. Tell us a bit more about your views on that.
Well, we're actually having our first inaugural event next week, and the whole topic is digital inclusion. So there's a really great charity called Citizens Online that tries to empower people to kind of get online and increase their skills. Just like you were saying, when you're doing assertive outreach, I also worked in the Start Homeless team. So, you know, if you think about kind of the homeless population, they often don't have access to smartphones or even a computer that's in a private room. It's usually in a shared facility. Again, like we said, people with mental health disorders often can have kind of socioeconomic sort of difficulties, and again, they might not have access. They might be sharing one computer between a family. Older populations, again, not as easy to use technology. So as much as there's kind of a way forward with digital solutions, I think we have to really think about within our own populations that we're treating. You know, I would hate it if everything suddenly went digital. I think it's been really hard for some of our patients to really get the care that they need. Then again, we have been able to provide it in the time they need it most, thanks to things like Zoom and Microsoft Teams. There has to be a balance. I think some of us are doing this sort of blended therapy at the moment, where we might meet someone on some occasions and then also use digital technology on other occasions. So I think we have to think of ways that we can empower people, and I haven't got enough answers about what different trusts are doing. Are they working with local charities or kind of government to try and donate technology to people who need it? It's the same is happening for children who've had to do schooling from home and don't have access to computers, for example. So.
It's interesting, isn't it, thinking what's happened in the pandemic and how have people adapted to homeschooling, to working from home, to offering digital therapy. I think it's a really interesting aspect to what's happened, and there must be huge learning that could be researched about what that's meant for people. Presumably, Amelia, from your point of view, it's also doing more digital interventions, which we were kind of absolutely forced to do during the pandemic. I mean, we've had service users, experts by experience, on Challenging Conversation who said, look, if you're asking me, would I like to see my clinician in person, or would I be happy to see them on screen? If the choice is between somebody arriving at my home in full PPE, so I can't see their face anyway, or seeing them online, actually, I'd like to see them online, but I would prefer blended. But presumably there is a big carbon footprint climate reduction really through the pandemic in some ways, because there's been so much less traffic going out, all the rest of it. What's your view on that? Is there any research been done on that? Or
yeah, I mean, the carbon savings are enormous because travel is one of the big hotspots within the NHS. Patients coming to and from appointments, and also staff coming to and from work. So if some appointments can go online, then obviously that has big benefits. And it saves time and money for patients as well, which may potentially improve compliance, like coming to appointments if you can do it sort of in a more convenient way. Yeah, I don't know the exact numbers, but I know they have been crunched and they're quite shocking. And I hope that a takeaway from the pandemic will be that it is actually doable to do a lot from home with technology. Yeah.
Presumably, from a research point of view, kind of looking at Jonathan a bit, this may not be exactly your thing, but one of the things that we aspired to do at SLAM, so I chair our mental health law committee, and so we didn't want to reduce our human rights reviews of patients' care. So and I would have to honestly say 60 plus mental health hospital managers who, we have some young people, but we have a lot of people who have retired and want to give back. And every single one of them almost transferred instantly, learnt the skills that they previously might not have had to use digital to hold review hearings. Amazingly impressive, the fact that people really wanted to continue to offer that. And one of the things that we'd hoped is that after every one of those review hearings, every one of those digital interventions, it would be very easy when people were online to find out from patients, well, what was the experience like for you? Something that in Australia, they've been doing quite routinely when they've introduced virtual digital processes. From a research point of view, is that being taken into account in the research world that you're aware of? Is using this big opportunity of COVID and its impacts, but some of the positive impacts to actually get more patient participation in research?
Yeah, I think there's enormous potential benefits for using tech as an adjunct to clinical assessment. So for example, if I asked you what was your mood like yesterday, I struggle to remember that, yet we routinely ask patients, what has your mood been like over the last 3 months? And actually, if we really want patients contributing to their own healthcare, what would be much better would be to enter into an app each day what your mood is like, link it up to your smartphone, so we know you can tell your clinician what your sleep has been like. Where I'm a little bit more skeptical about the use of technology is where it can be seen as a replacement for face-to-face assessment. So probably half of the patients I assess in the emergency department, I end up doing some physical examination of some sort, whether that's a neurological examination for a patient with a first episode of psychosis, or listening to someone's chest before I prescribe some benzodiazepines. And I think particularly as we have an aging population with more multi-morbidity, I think there'd be a risk of us neglecting the physical health of our patients if we're just assessing them remotely.
Very helpful, very helpful. What about you, Romy? What do you think? When you set up your special interest group, what do you think are going to be the challenges? Have you got a group of like-minded people, or have you got a few good skeptics?
I think we've got people willing to look at both sides of the of the coin, shall I say. We obviously have lots of kind of chief information officers, people who are very interested in how we're using the data. We have researchers looking at kind of apps themselves, and that's what I was saying around kind of safety. I think coming back to research, I think kind of adding to what you're saying, Jonathan, like this idea of digital phenotyping, getting people's data and how that works in real time, I think is really exciting. It's a really good time that psychiatry is actually at this height of innovation. We're seeing things like virtual reality, augmented reality, machine learning, artificial intelligence really being used to identify mental illness, to treat mental illness, and to support people. So I actually think it's a really, really exciting time, but we're also aware of the challenges. So we do want to challenge things like, okay, if we're going to be using smartwatches and collecting data, who has access to that data? How is it transparent? The Royal College has an informatics committee as well. So I think all these things that we might be collecting from patients, it's not just about teaching patients how to use Zoom and Teams, which has been challenging enough during this time, but it's making sure they're educated to know that actually when they're entering data into an app, if it's not one that we're giving them, who has access to that data? How can it be used against them? How are corporations making money from their when they just think they're putting in their mood every day? Who is that being sold to? And they're things I'm very passionate about. So
it sounds like a 10-year agenda. If you were sat here in 10 years' time, what would be the one thing you would feel, wow, I really, really made the world a better place because this is what happened through my digital special interest group?
I think it's very difficult. I think it's getting, like you were saying earlier, getting digital right, making sure it's inclusive. It's not just always from a kind of Anglo-centric perspective and how we're putting things out there, how we're collecting data, how we're using it. It's just, I think it's just empowering people to be able to use digital technologies in a way that serves them, in a way that helps their mental health, that doesn't hinder it. Yeah. So, yeah.
There's a really interesting question in the chat, which I think is, it kind of relates to your point to an extent, Jonathan, which is saying in mental health, for people that are not digitally excluded and are used to using digital and enjoy it, actually, we can make huge progress. And it's one of the things that I personally believed. I believed that digital is going to be a big way forward. It has been a big way forward. And if we in mental health are seen as some Luddite speciality that are resisting it, actually, we won't be able to play a part in shaping it ethically the way you suggest. One of the other things, the big movements, obviously, has been about integrating mind and body care again. So if we got the apps right and the wearables right, so that people looked at how their physical health impacts on their mental and vice versa, that's optimal. One of the comments in the chat is, I've come across a proportion of people whose physical ill health impacts their mental health, and this would be missed in remote appointments. It's a hard question, but I've been slightly surprised during COVID to find out that many parts of the physical health world are perhaps not as advanced about using digital and patient self-monitoring, self-efficacy to understand the variations in their physical health. Is that something you've encountered? Or do you think we're behind or ahead of the curve in mental health on working with people? Jonathan, you were the one that raised it as a...
Sure. I think actually sometimes the reasons patients struggle to engage with us isn't that we're too technological, is that our technology is actually too primitive. So when trying to take consent from patients and their relatives, I will send them this Word document that they have to print out and sign their name and scan it back to me. And many patients actually, they might have a smartphone, but they don't have a computer, and they certainly don't have a printer. And so it doesn't work for them. So I think actually it's a problem with us being too behind rather than too edgy with the tech.
Oh, so that's an interesting point, Romy, to take into your special interest group. What about this issue of physical health, people with physical ill health, people with, the common problems, musculoskeletal problems, diabetes, obesity? And I've always been amazed, there was a terrible, terrible program that somebody set up once called the Fat Kids program, which was meant to be a population health initiative to reduce obesity in children. And it seemed to start by saying it's all about stopping them eating food, as opposed to asking the fundamental question, what role does food play in their lives? What's the nature of the way they lead their lives? It means that, you know, some people are sometimes overeating. Do we think that in your lifetime that we're going to stop having national public policies that don't recognize the fundamental importance for people and for the system to understand people's mental well-being as a driver for their physical health? Is that something that you're passionate about, or do you think we've passed that? Do you think people now going forward do understand that if you're not feeling physically well, you also need to look at your mental health, because that may be driving it, or it might be the social circumstances? Victoria, if you could write an article on population health for one of the local newspapers, what would it say about that interaction between mind, body health? I think you're on mute, Victoria, or perhaps frozen a bit. I think it's frozen. Anybody else have a comment?
I was just going to say quickly that I think this has been a really interesting conversation that's come up more, again, because of the pandemic, because more and more people have realized the impact of having exercise or not having exercise on their mental health. And lots of people, I mean, I'm certainly someone that doesn't like going to the gym, but realizing that I have to walk every single day to feel sane and to feel like I'm not stuck in front of my computer and just working in front of the machine. So I think that this conversation's a lot bigger. And certainly when you were mentioning earlier around kind of technology and apps playing into this, I think it's something like 20 million smartwatches were sold last year. So that's just last year. So many of these now, they used to be just about counting your steps, but now they'll tell you whether you slept well or not. And you can correlate whether the exercise you did that day impacted your sleep, or even let you mood monitor, like you were saying, Jonathan. So I think that is becoming more integrated. And I think it is unfortunate sometimes that it takes corporations to remind us that we need to kind of look after our sleep, but at least it could be seen as being in the right direction.
Interesting. So I suppose some people, one question might be, if you were thinking about this from a sustainable policy point of view, is should having a smart gadget that helps you monitor your physical and mental health, should that just be, we give it to every child at school, we give it to all our trainees? Should, we talk a lot about social prescribing these days. Should we be pushing as a health system for our patients and ourselves to have as much access to technology that we can use for our own health, to improve our own health, and to see what it's like as we push for other external factors?
I don't want to dominate, but there is actually a school in America that has made it mandatory for the children in the school to wear the smartwatches. I'm personally against that, but we can talk more.
Yeah. Okay. Amelia, what do you think?
Yeah, I don't know if smartwatches are the answer. And in fact, I'm not sure if tech is necessarily central to the answer either, but definitely integrating physical health, mental health, and environmental health is really key. So yeah, it's things like exercise and having clean air. So we know that pollution is a massive contributor to, physical health is obvious, but also mental health. There's a massive amount of research in that area now, dementia, schizophrenia, strong links to the amount of air pollution. So sort of tackling all those things is probably going to be the way forward.
When you talked, Amelia, about the big global impact of climate change in the future, and the kind of mass movement of people and the number of displaced people, what do you think are the lessons? Do you feel the lessons that have been learned from policies on migration, the impact of migration on people in the past? If I look at the area where SLAM is based, 50% of our populations come from a very, very wide range of cultures, and many are first generation migrants. I came as a first generation, albeit Irish, but a first generation migrant to London, and it's very different. And many people, myself included, come from cultures where they had experienced trauma, conflicts, conflict situations. What do you think, what's the role that you'd like to see psychiatry play in that kind of understanding of impact of trauma, cultures, conflict, migration on people in the future?
Well, I think it's going to be necessary for all of us really to have an understanding about how those things impact mental health. And I think that should really be coming in sort of during med student syllabus and also postgraduate, so that we all kind of know a bit more about it, and how to manage the kind of things that might be coming up in those populations. But really, it would sort of prevention is better than cure. So trying to find ways to support people in the first place and prevent them from having to lose their homes and go through all these things would be better. And I know that it may not sort of seem obviously our role in psychiatry to do that, but I think sort of all health professionals and really all people have a bit of a part to play in doing that.
I think just even publicizing the numbers you talked about earlier, because people who know those know them, but I think the vast majority of people wouldn't.
Yeah, I mean, the Syrian refugee crisis, I think there were 5 million people displaced internationally. And even that sort of put a huge burden on mental health services in Europe, and physical health as well, obviously. But yeah, so just to put that in perspective, I think it's going to be something we'll have to think about more.
And it does feel extraordinary, does it, that we have a world where there's still circumstances where children are separated from their parents in difficult migration circumstances, without a recognition about the extent of the trauma and the terrible, terrible challenge that's going to present to children in their futures. Because we're coming kind of towards the end of our time, could each of you just think and reflect on what one thing would you like to see changed across your lifetime? Because remember, I hate to tell you guys, but you're probably all going to be working mandatorily till you're about 70, 75, I suspect, and paying taxes. So in that wonderful length of time you've got to lead your life, what's the one thing you would like to say? I remember having that challenging conversation way back in 2021, and this is what I thought I'd like to change, and it's happened. What kind of one thing would you really want to see changed?
I suppose for me, it would be about better collaboration with patients. And I think the only way that we can do that is if the patients have the tools and education, particularly at their disposal. So I know that's not possible in every way, but at all times. But I think that there is a greater scope for a lot more collaboration and have a much more moving forward with patients.
Love it, Victoria, as you would expect. Yes, because I think we all hoped, those of us, because when I was at your stage, I was saying I want to close the big institutions. I never want to walk in a psychiatric building where you can smell the food, the cabbage, the desperation, the despair of people. I never want to see people walking around in poverty in shoes that have got no laces. All the terrible things that happen to people when you get into neglected and closed culture systems, and yet many of them are still there.
What has amazed me, I currently work in perinatal, and there's a lot of resources that are specifically for perinatal women because of the concerns about medication and things. There are some excellent leaflets and resources that describe the individual studies, and the engagement patients have with that level of detail has been amazing and really kind of opened my eyes that we should be collaborating on a much, I suppose, higher level or academic level with patients about things. Not everybody wants to engage in that conversation, but we should be trying to broach these things.
I mean, I think it'd be great, Victoria, if we could put that into the link. And if anybody is interested.
Yes, I will.
Great.
It's bumped.
Northumberland Tyne and Wear is an organization that has 40 videos, YouTube systems where people with lived experience explain the different conditions and what could happen. And I'm also quite proud of the IAPT service at the Maudsley, where there again in Croydon, you put in IAPT, a service user describing why she came asking for psychological therapy, what was the process she had to go through as part of that treatment, and a therapist explaining what was on offer. And it's just completely wonderful. To me, that is the future of empowered people that can work together in partnership with their clinicians. Jonathan, what about you? What would you like to see different?
I think probably the promises of personalized medicine, we're going to identify your genes and give you this particular drug, have been oversold. But I think what I'd love to see would be stratified medicine. So you're diagnosed with depression, but we find that depression isn't a homogeneous entity. There are maybe 2 or 3 different groups of people who might respond differently to different antidepressants or different psychological therapies. And we can target in a broad way therapies to those individuals. And I think that would add a dimension to the collaboration with patients, because you could add that extra information. This is what I would tell everybody, and this is what I can specifically tell you. What's your view on that?
I think that would be wonderful, and I commend you for your beautifully accessible explanation, and also for not over-promising, because I genuinely think that many people in kind of my generation who were promised the biomarkers really rapidly. So don't worry about the medication and monitoring side effects, because actually all that's going to be a thing of the past, because we're going to so clearly be able to say what medication and what dose suits what kind of people. And I think the most wonderful thing about science is where people describe so clearly as you have what the potential is, and also realistically what it might take to put that in place. So thank you for that really, really great explanation. Thank you. Romy, what do you want to see? What do you want to say was different?
I would love to look back and see that we had advanced in mental health equality, whether that's digital or otherwise. I think it's just the most important thing in our country, across countries. That would be something I would love to look back on and see that we've made more progress. And we're having challenging conversations, but I would like to see real change.
And so for me, that would mean that we genuinely stopped over the overrepresentation of sectioning people from BAME communities in our services. And the question is exactly how are we going to make that happen? And again, I commend the organizations who've managed to reduce their use of detention by virtue of using and putting into the training far more negotiation skills, advocacy skills, information giving skills, and understanding of the real life of the person, not just what somebody presents with. I think there's so many things. I agree with you completely. I think if we could achieve a numerical, feasible, safe percentage reduction in the use of detention, I think it would say something very, very different about us as a mental health profession, because that is what people don't understand most about us is why do so many people get so far on the journey of being very unwell that we end up having to section them? Why do 70% of the people that present in crisis are people who are already known to the system? What is it about our advanced care plans, advanced decision? Can we get a shifty on? And can digital help that? Can our biomarker science help that? Can our population explanation approach, can that help that? Amelia, I have a bit of a sense of what you might be wishing for, but do tell us.
I'd like to see really a paradigm shift within psychiatry and beyond that, because we can all collaborate sort of within our own trusts, but it would be really good to see sort of people calling on our local leaders and politicians and institutions to take action to mitigate climate change, because the exact amount of warming and subsequent suffering that will occur sort of depends on the choices that are made in coming years. So I'd really like to see psychiatry adapting to those challenges and also playing our part in preventing the crisis.
Great. Listen, you have been amazing panelists. I know for many of you, this was your first time in this situation. I've chucked all sorts of questions and problems at you. I've asked you to design a nirvana for mental health, but I have to say, I feel really proud to have met young dynamic leaders like you. I feel very confident about the future of psychiatry with such fantastically broad, sensible, feasible, practical comments. So thank you so much indeed for participating. Take care. Have a lovely afternoon. Bye.
Bye.